We're going to see now an important complication of coronary disease that is not often diagnosed, the myocardial infarction involving the right ventricle. It's usually associated with infarction of the inferior wall of the left ventricle. Here is an example. IV septal wall contracting well, posterior lateral or inferior wall, depending on the inclination, is fibrotic with an old myocardial infarction in its basal portion. In the parasternal long axis of the right cavities, right ventricle inflow, outflow, tricuspid, anterior and posterior leaflet, and right atrium. Notice the inferior wall of the right ventricle does not thicken. It's fibrotic. What we see as movement of this wall is just pulling by the others normally contracting walls. This is an obvious infarct of the inferior wall of the right ventricle. It may be even more extensive than the one we're seeing here in the inferior wall of the left ventricle. One more example. There is a classical inferior wall infarction seen in this apical two-chamber view. In the subcostal four chambers, the inferior wall of the right ventricle is thin and not thickening, much better seen in this short X. Look how the right ventricular inferior wall is very thin and does not thicken. The wall is also slightly dyskinetic. You can also see the involvement of the inferior IV septum. See how it is thinner here. Another case, good contraction of the walls except for the fibrosis of the inferior wall of the left ventricle. If you pay attention to the timing, you'll see that when the left ventricle contracts, this inferior wall of the right ventricle expands. It's dyskinetic. This dyskinesia is better seen in the subcostal view. The right ventricle inferior wall is thin, dense, fibrotic, and dyskinetic. Look at each systole. The expansion of this wall pushing the diaphragm and also the liver. Right ventricular infarction is very frequent. You have just to look for it in all patients with left ventricular inferior myocardial infarction.